the talk, which will be chaired by Dr. Meghna Mukund, ma'am. It's an honor to introduce Dr. Meghna, a distinguished figure in the field of anesthesia and critical care. Dr. Meghna completed her MBBS and MD anesthesia and critical care at Kasturba Medical College, where she laid the foundation for her illustrious career. Dr. Meghna's journey in medicine has been marked by significant milestones. She began by honing her skills in the cardiothoracic department for 2 years before establishing herself as a sought-after consultant anesthesiologist in both general surgical fields and neurosurgery in Mangalore for several years. Dr. Meghna pursued further specialization with prestigious fellowships in critical care and regional anesthesia in the United Kingdom. Returning to India, Dr. Meghna contributed extensively to Yenepoya University, where she served as the ICU in charge and chief coordinator in the simulation lab, demonstrating her leadership and commitment to advancing medical education and practice. Currently, Dr. Meghna holds the position of professor in the Department of Anesthesia at Yenepoya University, where she continues to inspire and educate future generations of medical professionals. Her recent appointment as the head of department of the emergency department in Yenepoya underscores her dedication to enhancing emergency medical services and patient care. I welcome Dr. Meghna Mukund, ma'am.
Thank you so much, Dr. Sandeep, for that beautiful introduction.
Now I would like to introduce the speakers for this session as well, starting with Dr. Zakia Maryam. It's my pleasure once again to introduce Dr. Zakia Maryam, ma'am, a distinguished anesthesiologist joining us today. And Dr. Zakia is a specialty registrar at the East Midlands North Deanery in the United Kingdom, where she has made significant contributions. Dr. Zakia holds an impressive academic background, starting with her MBBS from AJ Institute of Medical Sciences, followed by MD Anesthesiology from Yenepoya University. She has further specialized with certifications such as the SAIC from the European Society of Anesthesiology and Intensive Care, and FRCA from the Royal College of Anaesthetists. Her commitment to education and teaching is exemplary, serving as faculty for various prestigious programs, including the Coventry, Northampton FRCA, and the UK-Ukraine Symposium. Dr. Zakia has also authored a chapter in a prominent anesthesia textbook and which demonstrates her expertise in trauma anesthesia and tourniquet application. Recognized for her excellence, Dr. Zakia has received numerous accolades, such as the Exceptional Teaching Award from the Frimley Health NHS Foundation Trust in 2023. Her dedication to teaching has been further highlighted by nominations such as the Excellent Teacher from St. George University for her role in medical student placements within the anesthetic department. Welcome, Dr. Zakia Maryam.
Thank you, Sandeep, for that kind introduction.
And we move to speaker 2 for the same session, which is Dr. Payal Chandrashekar. I'd just like to introduce Dr. Payal, ma'am, again from our very own JSS. She's a distinguished anesthesiologist with an extensive career and impressive qualification, currently serving as a senior resident at JSS Medical College in India, and having previously worked as a specialty registrar in anesthetics with focus on trauma, hepatobiliary, obstetrics, as well as critical care at the Queen Elizabeth Hospital in the UK. Dr. Payal brings a wealth of clinical experience from diverse healthcare settings. She completed her MBBS from JSS Medical College in Mysuru and pursued her MD in anesthesiology in Yenepoya Medical College. She has furthered her professional credentials with notable certifications, including the EDAIC from the European Society of Anesthesiologists and Intensive Care, and the FRCA from the Royal College of Anaesthetists. Her dedication to education is evident through her participation in various workshops and courses, such as the Final FRCA Booker course, the Final FRCA CRQE Club, and the Coventry Primary FRCA OSCE course. Dr. Payal is also a certified ACLS provider and has completed advanced life support training under the Resuscitation Council UK. Welcome, Dr. Payal. Over to you.
Thank you, Dr. Sandeep, for your kind words.
Good evening, everyone. Thank you for that kind introduction, and a big thank you to the organizers of this course for inviting me to deliver this talk. Over the last few years, I've had the opportunity to experience OSCE exams as both a candidate as well as an examiner. With this talk, With this talk, I hope to introduce to you the concept of OSCEs, touch upon how this style of exams differs from traditional ones, and then convince you that this is a relevant and necessary change to be made to our Indian assessment systems. My colleague, Dr. Chandrashekar, will then take you through the process of designing and organizing OSCEs, explain how to standardize the simulated patient and examiner, and also enlighten you about some commonly used scoring systems that can be used for assessments. Recently, the National Medical Council of India published its goal to generate Indian medical graduates with knowledge, skills, and attitudes of an effective physician who is also globally relevant. Now, what does that mean? It means we want doctors who are good clinicians, but also natural leaders and responsive ethical professionals with exceptional communication skills and compassionate care. All of this is good, but how do we train and ultimately test these qualities? One way to quantify could be through OSCEs. From the pre-programmed survey sent out to all of you, I can see that about 20% of you have some sort of experience with OSCEs. For those who haven't, I will begin with the basics. My apologies to those who might find this a repetition of things that you already know. I assure you that the later topics of design and implementation you will find much more interesting and relevant. So, what are the OSCEs? Functionally, it is a timed clinical examination where the candidate moves station to station on a circuit. At each station, the candidate is required to perform a specific clinical task in a simulated setting where the interaction is mostly with the standardized simulated patient or actor. A facilitator may be present to ask questions, and an examiner would score the candidate against a standardized checklist. In order to decode the term OSCEs, we need to understand what the word objective and structured means. The word objective implies that each station tests a specific competency against predefined standardized checklists for content and scoring, and it is not examiner dependent. The word structured means that all candidates have the same tasks to perform in the same time, at the same difficulty level, against the same content with a standard assessment tool. Here, as an example, I've included the primary FRCA OSCE examination circuit. As you can see, it's a group of stations about 10 to 25 in number, each lasting about 5 to 20 minutes depending on demand. So why use OSCEs as an assessment tool? In more technical terms, it's an exam or a summative assessment that takes into account both non-technical skills as well as applied clinical knowledge. Each skill is tested in terms of performance as well as degree of competence. That is, it's also testing psychomotor domains, attitudes, and behaviors of the candidate. These aspects differ greatly depending on the environment a person is subjected to. Many students might find that a teaching environment is quite comfortable and sheltered, but when faced with reality, they might find it quite stressful. This discrepancy could lead to risk of adverse events and worse, a sense of underconfidence in themselves, which may have a further negative impact. This is why soft skills are important. Soft skills or non-technical skills can be defined as cognitive, social, and personal resource skills that complement technical skills. They contribute to safe and efficient task performance. These typically include situational awareness, decision-making, leadership, and management of stress and fatigue. Here on the left is a handbook of non-technical skills for anaesthetists commonly used in Scotland and England. It attributes nearly 80% of all medical error and adverse events to deficiencies of non-technical skills. On the right is another piece of evidence published in the British Journal of Anaesthesia. It details how the lack of soft skills limits human performance and leads to error. It then goes on to describe 4 key soft skill categories for people of this specialty, namely task management, team working, situational awareness, and decision making. Now, in the military, the importance for live fire training cannot be overstated. Mimicking realistic scenarios is essential for preparing these soldiers. Similarly, in aviation, pilots are trained and assessed on non-technical skills that are protective for flight safety. As doctors, we care for others' lives, often in high-risk situations. It is therefore essential to be armed and empowered by honing non-technical skills. Traditional training methods often fall short of this. Simulation training with high fidelity, realistic scenarios can help bridge this gap. By artificial representation of the real world and replication of clinical scenarios, skills can be transferred or acquired through deliberate practice rather than an apprentice style of learning where you would see one, do one, and then teach one. We would much prefer see one, practice many, and then do one instead, where mistakes can be made and learned from without the risk of harm to a patient. At this point, I would like to introduce two important concepts to understand the importance of simulation in OSCEs. The first is Payton's four-step approach, which is used for teaching procedural skills. This was introduced by Walker and Payton and describes 4 steps. The first is demonstration, where the teacher or the trainer would demonstrate the procedure. Then is deconstruction, where the trainer would break it down into easily understandable steps. Then the comprehension of the trainee would be tested by asking them to talk the trainer through the steps. Finally, the trainee would be expected to perform the procedure on their own. By repeating this process, the trainee becomes unconsciously competent at the procedural skill they're learning. The evidence supporting this method is robust, providing and proving that it is an effective method of teaching where trainees retain more for a longer time and needed less time to perform the procedure that they were learning. The next is this, Miller's pyramid. In 1990, Miller, an American physician, introduced this pyramid for performance-based assessments. He argued that the traditional methods relied too much on testing knowledge rather than assessing how the individual may behave in real life. His model divides development of clinical skills into 4 hierarchical processes. On the lowest level, as you can see, is knowledge. This is tested by our traditional written exams and MCQs. Next is the application of the knowledge, assessed by essays and clinical problem solving. In the third tier is clinical skill competency testing, where performance as competence is tested with simulation and OSCEs. Finally, on the top tier is clinical performance, assessed by direct observation and assessment in real clinical situations in the work environment. Introduction to this concept led to increased use of OSCEs in medical training. Now, are there any systemic problems in our traditional exams? Let's look at some differences. First, let's compare OSCEs to conventional clinical exams. Medical schools in India have traditionally assessed students with long and short cases. Each examinee is tested with different patients, with different clinical issues, and against different examiner standards, which some may say sounds a bit unfair. But with OSCEs, each examinee gets the same patient, the same issue, and is tested against the same standard. Additionally, a wider content can be tested at different stations with minimal deviation from the topic or script and within a strict time frame. What about OSCEs versus the written examination? This French study, conducted by Lebda et al., concluded that compared to other testing modalities, the score distribution was larger. Therefore, it made OSCEs more discriminant. Also, significantly lower scores suggested that OSCEs brought additional value to traditional written modalities. It tested larger variety of skills and in a different way. Having looked at all of these differences, what measures the quality of an exam? This is a repetition of what was in the keynote, but I will go through it because I have some evidence as well. Now, 4 criteria must be considered for this. Validity, whether the exam measures what it intends to. Practicability, is the exam usable in terms of time and cost? Reliability, does it produce consistent results? And finally, objectivity, is there a bias and is it uniform in examination? So let's see if OSCEs meet these criteria. Here are a few pieces of evidence. The first is a report published in the BMC Medical Educational Journal by Karam and colleagues. They concluded that with proper application of standard setting techniques in each criteria, validity was achieved. The criteria they looked at were content, response process, internal structure, and alignment of results. The next study, conducted in a Nigerian medical school, found a significant difference between medical scores in long case versus OSCE, implying OSCEs are more reliable than traditional methods. They also found a positive correlation between the 2 forms of assessment, implying that they can be used in combination with each other as a summative modality. Lastly, this article detailing the experience of OSCEs in PG training and assessment in psychiatry in Manipal was published in the Indian Journal of Psychology. It comments on how in India, students from different backgrounds and cultures travel for exams and are subject to examiners and patients of an equally different background. Here, the outcome of an exam is often dependent on the patient the candidate is allotted and also the examiner who is testing them. Conversely, with OSCEs, they found that all of this was minimized, ensuring an impartial and unbiased outcome. Also, OSCEs can be carried out without subjecting patients to repeated discomfort and distress of interviews and examinations. So, taking all of this evidence into consideration and looking at everything else that is out there, I can say that OSCEs can meet all the 4 criteria to be regarded as a good assessment modality. Are there any limitations? Well, yes, but these can be regarded as misconceptions hindering implementation of OSCEs rather than true drawbacks. Students may report that it is difficult to manage time and stress. One may argue that this is one of the aims of such an exam. Training can help desensitize the students to such effects, which is an important life skill as well. Both Payal and I can attest to this on what an improvement exams such as these have made on our self-confidence and leadership skills especially. Some criticize that with OSCEs, there's a loss of integrated approach to patient management, that OSCEs test knowledge and skills in a compartmentalized fashion rather than looking at the patient as a whole. This again is a misconception. In the next talk, you will see how the scope of the exam can be broadened to achieve more. Is it time and effort consuming? Yes, but only during the initial design process and pilot runs. However, once established, they're quite simple to repeat and improve as needed. Finally, cost. There's a lot of argument out there saying OSCEs can be quite expensive, but there's enough research to support that OSCEs can be organized and conducted with limited resources. In conclusion, as teachers and trainers, with the aim of generating all-rounders and achieving the best possible outcome for the lives of the patients that we care for, we need to arm our students with not only good clinical skills and acumen, but also inculcate in them effective soft skills, attitudes, and abilities to make sound decisions and treat patients in a safe, empathic manner. All of this can be facilitated with OSCEs. Although it's not perfect, it is proving to be a good assessment tool and can be added on to improve the existing traditional exam system. Thank you all for listening. I will now hand over to my colleague, Dr. Payal Chandrashekar.
Thank you, Dr. Maryam, for that fantastic introduction. I resonate with your experience when it comes to the OSCEs and competency-based model of training and assessment. And moving forward with this evening's talk, I'm going to be offering suggestions on how a seasoned team of experts can go about organizing a high-quality OSCE session in an effective way. So please have the handout that's been sent to you in hand. So now that Zakia has checked off 2 of the 4 Ds, to launch the OSCEs, firstly, we need to develop it and then deploy. Let's begin then. Firstly, form a team. It's not a one-man job. So form the OSCE committee and assign specific roles to them. So who is going to be part of this team? It is a group of subject experts. So who is the main guy? Who is going to be leading this team? It is the OSCE coordinator, and there are other experts on the team. So the OSCE lead, it's a no-brainer that they are going to know this pattern of exam in and out. They are going to be in sync with another key player on the team, the simulation coordinator. Now that's a given. Zakia has already impressed upon how important simulation is for the OSCEs. So there are other members on this team, the most important being the station designer and other experts. I am going to be elaborating on each of their roles as I walk you through designing a station with an example. Now, when we aim to build anything strong, we need to lay a good foundation. That brings us to the OSCE blueprint. So as a station designer, what do you need to be aware of? you need to be aware of the intended learning competencies. So these are most likely tasks or situations or scenarios that you would have dealt with in your everyday work or practice, given the expert that you are. But please go through the NMC curriculum, liaise with other experts, discuss. Now, why do you need to do this? You need to ascertain your knows. You need to differentiate between your must knows from, it's nice to know, and make a short list. Now that you've jotted down your competencies, you need to jot down your stations and concepts. So now consider that you want to organize an OSCE session for a group of medical undergrads. Many of you MEU experts and simulation facilitators are going to be aware of these basic OSCE stations, such as history taking, communication, examination, and so on. And now here are some of the concepts that you would want to consider testing. Now that you've jotted down the stations and concepts, begin to create a simple matrix like this. Strike off at least one task against one system, such as history taking for cardiovascular system. You want to test communication with either gastrointestinal system or CNS, data interpretation with respiratory system, and so on. So on this simple matrix, now begin to build on this simple matrix by allocating specific tasks against each of these tasks you have striked off. For example, with history taking and cardiovascular system, you give the candidate a patient who's got high blood pressure to elicit the history from. For communication and GI system, now there's a patient who's come in for an inguinal hernia repair. So ask the candidate to consent this patient for surgery. You want to test how the candidate copes with difficult situations. You give them a task to break bad news. Now, the candidate is tasked or assigned to inform a patient who's been diagnosed with brain tumor. Now, by doing this, you're testing concepts of central nervous system and coexisting diseases as well. For data interpretation, give them a chest X-ray to interpret. Now, this simple matrix can be upscaled in two ways. It could either be made difficult for the same stage of training, or it could be refashioned for an advanced stage of training. Now, how do we do that? We add layers of complexity to this matrix. We add variables. So consider part of the previous matrix, the history and communication. So for history, you've given the candidate a patient with high blood pressure. Now add another variable to this, make the patient anxious. So for communication, now the patients come in for an inguinal hernia repair and the candidate is supposed to consent them. Now make this patient needle phobic. In this way, you've made it more complex. Now zooming in on the OSCE station in itself, are they spotters? How are they distinct from spotters? So like spotters, they are time-bound. They do test the same learning competencies, but they do not just test memorized facts. They do not just test technical skills. There is a key difference. Considerable weightage is assigned to soft skills and marks are allotted for the same. So it tests quick thinking and rational decision-making, and all this in a limited time frame. And this adds to the make-believe stress. So now many of you MEU experts and simulation experts are going to be aware of these three basic OSCE stations. The manned station, where the examiner is present throughout the station. The unmanned station, where there is no examiner present, but of course it's an exam. So it's invigilated by an approved faculty. And here the candidate is given a paper-based questionnaire or a computer-based questionnaire. That brings us to the tech-based stations, which could be a computer-based questionnaire, or it could be incorporated with simulation. Now, consider that you want to organize an OSCE sitting for a group of first-year MBBS students. Physiology is the subject. Spirometry is a common task assigned in physiology practical exams. Amongst these first years, choose one. Let's call her Priya. Now, what kind of stations can be designed for Priya? Consider that a patient has been advised spirometry. Now, Priya's task is to elicit relevant information from this patient, that is history-taking station, and she's got to do all of this using non-medical terms, and marks are allotted for this. Marks are also allotted for Priya introducing herself, ensuring that she is speaking to the right person, and in the end, concluding and ensuring that they've got no further questions. Now, this patient who's been advised spirometry is going to have queries. They're going to ask why they need this test done. Why is this test important? How is it going to be done? So now assign Priya the task to discuss all of these with the patient. This brings us to the communication station, which, unlike history taking, is a two-way street. Now, Priya is going to be gathering information as well as providing information to the patient, and she is going to be reassuring the patient. So marks are allotted for this. Also, like history-taking station, Priya introducing herself and summarizing in the end and ensuring that the patient's got no further questions also hold value in terms of marks. Many communication stations test the candidate's ability to break bad news, handle difficult situations, and assess how the candidate caters to the patient's emotional needs. Now, moving forward with procedural skills, it's straightforward. Assign Priya the task to perform the spirometry. Now, majority of the marks is allotted for the technical aspect, but Priya seeking permission from the patient, that is implied consent, and Priya ensuring that she's got everything that she needs in terms of equipment and personnel, doing her safety checks, and Priya putting the patient at ease while she's performing the procedure, all of it holds value in terms of marks. So now, moving forwards with the next station, data interpretation, it's straightforward. Give Priya a spirometry result to interpret. And given that this is a physiology station, it's going to be normal values, but you could check Priya's understanding of concepts. Now, with physical examination, like procedural skills, Priya is, the next slide's up here. With physical examination, Priya can be assigned the task of measuring the patient's blood pressure. Now, like procedural skills, Priya is not just allotted marks for just the physical examination, she's also allotted marks for introducing herself, hand hygiene if applicable, and also seeking implied consent. So now Priya has moved on to her second and third phase of MBBS. She's back to sit her OSCEs. So Priya can be assigned a patient who's got lung issues, and she can be given a set of abnormal spirometry results. Now, what is Priya's task? Priya has to gather relevant information in terms of history taking, data, and she has to be situationally aware. Priya has to prioritize her tasks based on clinical urgency. She's got to escalate and seek advice from experts and communicate this back to the patient. So now all this is a combination of all the stations we've discussed so far, and that brings us to clinical problem solving. This, when incorporated with simulation, is known as interactive resuscitation. Simulation-based or scenario-based simulation stations, these form the crux of OSCEs when it comes to postgraduate examinations, especially with acute care specialties. Now, let's look at how to design an OSCE station. Let me start by deconstructing a communication station. Let's begin with a screenplay. Now, we need a script writer to write the screenplay, to decide how to run the show. So that's the station designer. Consider yourself to be the station designer. Have a mind map. Think, what am I testing? The intended learning competency. And have I understood the clinical history well? And who am I designing the station for? Is it an undergraduate? Is it an intern? Is it a postgraduate in training? Or is it a postgraduate who is going to sit the exit exam, about to be certified as an independent practitioner? So now all of these are important questions. And who are you writing the script for? Now bear in mind these three important people: the candidate, the examiner, and the surrogate. Let's begin with the candidate. Be practical with the candidate. Remember, there is a limited time frame. So the candidate, you need to design a station in such a way that the candidate is able to complete the task so that they have full potential access to all of the available marks for the station. The next important thing with the candidate is the set of instructions that you are going to write for the candidate. So these set of instructions are going to be pasted outside the OSCE station, and the candidate will just have 1 minute to read this set of instructions. So be concise, brief, and clear, but you need to give all of the relevant information for the candidate like this. So here, you have to mention what kind of station it is. The previous slides are here. Sorry, yeah. So you have to mention what kind of station it is. So it's a communication station. The time allotted, that is 5 minutes. And please do not get confused. The candidate has 1 minute to read the instruction, but the time mentioned here, 5 minutes, this begins when the candidate steps in and the scenario plays out, and they will have 5 minutes to complete the task. And again, you need to mention in the instruction that the examiner cannot comment on anything. And you need to mention the case scenario. So this is a patient who's come in for an orthopedic surgery. She's terrified of needles and she's refused to have bloods taken. And the candidate here is the intern doctor, and their task is to counsel the patient. Now, this can be upgraded for a postgraduate doctor. So here, the framework of the instruction remains the same. So you mentioned all of the same, that there's the station, the time allotted, and all of this. The case scenario remains the same, but the candidate's role has changed. Now it is a postgraduate, it's an anesthetic doctor, and they not only have to counsel the patient, but also negotiate options with the patient to plan the anesthetic management. So now moving forwards with the surrogate is the standardized or the simulated patient, the SP, and these are patient actors. We need to recruit patient actors and train them. Why do we need to train them? To ensure consistent performance. Remember, this is a objective exam. So now as a station designer, you need to provide a set of instructions to the patient actor. So now that would be, that is given in page 16 and 17 of your handout. So moving forward to the next slide. So here, on the left-hand side, the patient actor has been given all of the information about this make-believe patient that they're going to be enacting. And all of this has been given in layman terms, like shin bone for tibia. On the right-hand side, as you can see, they have been given what the problem is. They're terrified of needles. And it is also mentioned that this bit is not to be seen by the candidate. So now on the next slide. So again, the surrogate is given the information that what the candidate is likely going to be discussing with them, what kind of options they're going to be providing them. Now, all of that has been given here. And they are also given or instructed on how to conclude the station. So in this case, they have to absolutely refuse the cannula, no matter what options they are provided by the candidate. In this way, you've stimulated the candidate to a point of escalation. Now, what does that mean? That means that if it is an intern doctor, they are going to seek for senior advice. Now, you might be wondering, are we not training well-rounded clinicians who are going to be making such decisions and going to be managing such patients? Now, that depends on the stage of training. You need to test limitations as well. If this is an intern, then there is scope for escalation. But if this is a postgraduate, then they need to exert leadership and use clinical judgment and manage this needle phobic patient. So please hold on to your thoughts. I'll get back to this in a bit. Now, I'll explain the role of the examiner, and most seasoned examiners will already be aware of the rules. They need to observe, contribute to the good conduct of the exam, follow a stipulated guidance, and ensure uniformity. But why train the examiners? So this is a unique format of the exam being newly introduced to our system. So one must orient themselves, familiarize themselves with the scoring guidelines. This reduces variation and bias. This is to improve objectivity. The don'ts are what is more important. The examiner must refrain from prompting, should not comment on any aspect or performance of the candidate, should not deviate from the stipulated guidance, and should not provide any clues, even if it is in the form of non-verbal cues. Now, if you look at page 18 of your handout, this is a set of instructions provided by the station designer for the examiner. And of course, this is not to be seen by the candidate. On the left-hand side is a set of generic instructions for any communication station. And on the right-hand side, this is a scenario-specific instruction. You can have a look at this in your handout in leisure, focusing on the most important role of the examiner now, how to award marks. Now, there are many ways to do this, of which the domain or the rubric system and the checklist system are commonly used. For the purpose of this talk, I'm going to be speaking about the checklist system. Now, as a station designer, you need to construct a checklist. Now, how do we construct the checklist? Firstly, we're going to be jotting down mini tasks known as items. Now, for the same communication station, the candidate here is an intern, and it is a needle phobic patient. Now, we have jotted down your items, that is the candidate introducing themselves, reassurance, empathy, building rapport with the patient, explaining what a cannula is, why bloods need to be taken, and what happens in an emergency, and the point of escalation, and how they are going to be concluding. That is on the next slide. Yeah, so how they're going to be concluding. So these were most likely the items you were going to include for an intern. So now, if you want to make that station more difficult for the intern or refashion it for a higher stage of training, you could consider including these additional items, such as the candidate could offer the patient some benzodiazepine tablet, or offer them lignocaine cream, or explain to them about an alternative form of anesthetic. So all of these items will be formally incorporated onto the checklist along with the scoring system. Again, there are many ways to score, and there is no universal standard. The global scoring system and the numerical scoring system are commonly used. So now let's look at the global scoring system. So on the left-hand side are the items that I just discussed, along with the global scale that uses descriptors. So if the candidate achieves the task, they get striked off as adequate. If they underperform or do not achieve a task, they get striked off as inadequate. And with tasks with multiple options, on completing all of those, they get striked off as good. The examiner also rates the overall performance of the candidate by using these descriptors. So in comparison, when we look at the numerical system, so here's the checklist with the items on the left-hand side. And as the name itself suggests, we are going to be using numbers. So on achieving a task, we score them up 1, and on underperforming and not achieving a task, we give them 0, and the score is summed up to give the total candidate score. Now, what is better than these two is combining the two methods, and that would be using both the global and the numerical scoring system. As you can see here, And if Zakia moves on to the next slide, this is the complete checklist for the intern. And if you go back to the previous slide, yes, this has all of the items on the left-hand side. It has the global scale with descriptors and also the numbers. So now I'm going to be discussing the key differences between the intern checklist and the postgraduate checklist. With the intern checklist, the previous slide, please, Zakia. So now we award more marks for the intern introducing themselves, ascertaining what the problem is, and reassuring and building rapport with the patient. So they're going to be explaining what the cannula is. They're going to be explaining what happens if the bloods are not taken and what happens in the emergency. The next slide. And also considerable weightage is allotted for point of escalation, that is them seeking senior advice and seeking expert opinion from the anesthetist. Now, when we look at the postgraduate checklist, in contrast, although we are awarding marks for introduction and building rapport, we award lesser marks for that. And there are common items on the checklist, such as the candidate explaining about the cannula and why bloods need to be taken. And if we move on to the next slide. So there is just 1 mark allotted for seeking advice from the senior. That is because at this stage of training, the postgraduate is expected to explain, to manage this needle phobic patient, because it is on the onus of the postgraduate to exert leadership and use clinical judgment. So now, only in exceptional circumstances, when it is a very difficult patient, are they going to be seeking advice from a senior, and that's why they get scored 1 point. But otherwise, if we go back to the previous slide, marks are allotted for the candidate offering other methods or providing options to the patient, such as an EMLA cream or a benzodiazepine tablet for anxiety, or offering to put in a smaller gauge cannula. And also specialty specific knowledge is tested. If we go to the next slide, the candidate explains inhalational induction, that is, they explain other methods of putting the patient under anesthesia and the risks involved with it, all in layman terms. So these are the differences between the intern checklist and the postgraduate checklist. Now, how are we going to conclude the checklist? So all of the marks are summed up to give the candidate score. And also the examiner rates the overall performance of the candidate using these descriptors. And if the candidate scores low marks, then the examiner is required to provide a feedback for the candidate. And this is handed over to the candidate with your result for the candidate to reflect on their performance and improve their performance in the next session. Last but not the least, the examiner is expected to reset the equipment in between candidates when the next candidate is reading the set of instructions outside the station. So there is going to be just 1 minute for the examiner to reset the station. Now that brings us to resources. So what are the resources? These are the gadgets that are going to be used in the OSCE station, be it the stethoscope or a stool or an examination table. So it is for the station designer to pay attention to all of this and pen this down in the guidance under the header resources list. Now, who is this for? This is for the OSCE station facilitator, who is going to sit down with the station designer. They are going to go through the script. They are going to understand how the station designer intends this station to be played out. They will understand the roles of the examiner and the patient actor, and they will oversee their performance during the mock sessions and provide them with the feedback to minimize bias and to improvise. Now, the essence of the talk is how and why to set the standard. So traditionally, most medical exams have a pass mark of 50%. So now why not carry on doing the same? This produces varied outcomes and this leads to bias. And remember, we are aiming for an objective exam. So now I'm going to be speaking about descriptors. Remember, with global rating, the examiner is going to rate the performance of the candidate using descriptors. So now, amongst these, who is a borderline candidate or a minimally competent candidate? So that depends on the stage of training and the level of difficulty of the station scenario. And who decides this? This is decided by the group of subject experts, and they're going to sit down and they're going to decide this either after the mock exam, and it is essential to do this after the full-scale exam. So now the borderline candidate is a candidate who performs between a novice, that is a fresh beginner, and a competent candidate. And that depends on the stage of training, whether it is an intern or a postgraduate. And it also depends on the level of difficulty of the scenario for that stage of training. So now this is important to understand the methods by which we are going to set the standard. So looking at the methods, the commonly used methods are the borderline group method, the borderline regression method, and the modified Angoff's method. So again, there are many ways to do this. So to keep things, although all of these methods are objective and reliable, to keep things simple, choose the borderline group method. Now, consider an OSCE exam sitting. So there are 10 stations in this OSCE exam. So there are 10 different examiners for these 10 different stations. And this is for a group of 20 candidates. So consider one station. The first station is a history-taking station. So this station will have examiner 1. And for the history-taking station, it will be the same examiner who is going to be examining all these 20 candidates. Now the examiner will rate the performance of every single candidate using these descriptors. And he is also going to be awarding them scores. So now once that is done, all of these borderline, the candidates who have been described as borderline by this examiner are going to be grouped and their scores are going to be averaged. So that forms the pass mark or the cutoff score for that particular station. Now this is repeated for the station 2, which has examiner 2. So this is a different examiner for a different station. Again, this examiner will score and rate the performance of all 20 candidates, and the same method is repeated and a cutoff score is calculated. This is done for all of the stations. The cutoff scores of all the stations are summed up to give the cutoff score or the pass mark for the entire examination. So now looking at the borderline regression method, it uses the same variables, but here a scatter plot is sketched out. And looking at modified Angoff's method, now that is a highly acceptable method used in many of the high stakes examinations. Here the experts are going to define the minimally competent candidate and the likelihood of this candidate achieving each of the items on the checklist, and a range of calculations are performed. So now, in keeping with the time of this talk, the details of modified Angoff method and the borderline regression method will be sent out to you in a handout after the webinar. Moving forward, so now here is a piece of evidence that shows that the checklist scoring system, the global rating, and the borderline regression method gives us a fair passing score. And we have another piece of evidence which shows that the modified Angoff's method is an acceptable method. So now that we have passed designing the station, we have trained the examiners, and we have prepped the actors and the students, we need to test run this. That brings us to the role of other experts on the team. That is the expert to revise, who is going to read through the script written by the station designer and vet the scenario and reduce to ensure to reduce ambiguity. And once that is done, we need to validate. So now how do we do that? We need to pilot the exam, conduct mock exam. And now at this point, we need experts who have ideally not been involved in designing the station. So now we play out the stations, we have the candidates, we have the examiners, and we have the patient actors. And these experts are going to observe how the station is played out, how the candidate copes with the scenario, how the examiner standardized, and are the patient actors consistent? And is the patient actor performing uniformly with every single candidate? And at the end, a debriefing is done and feedback is provided for everybody and the stations are revised. Now, here's a piece of evidence that shows that piloting of OSCEs makes it possible to have standardized assessments. And once piloting is done and everyone is happy, we conduct a full-scale exam and publish the results. Now that brings us to the end of our talk. A post-webinar handout will be emailed to you all after the webinar. And if you have any further questions, please contact the team on either of these emails provided here. Dr. Zakia and I would like to thank you all for taking the time to attend our talk. We extend our heartfelt gratitude to Dr. Meghna Mukund, ma'am, our teacher and inspiration. Over to you, ma'am.
Thank you so much, both Zakia and Payal. Can you hear me?
Yes, ma'am.
Yeah, thank you so much. I feel it seems very fitting to have you talk on OSCE because you've been on either sides of the OSCE table. You've been both a student and an examiner with respect to OSCE. So thank you so much for telling us all about how to precisely conduct OSCE. And Zakia, I'm very happy that you brought out the importance of non-technical skills. And I want to tell the audience, of course, those who are simulation experts do know this, but who are naive to simulation, non-technical skills deficiency, or what you call as human error, is responsible, like Zakia said, to 80% of the medical errors. But mind you, all of it or most of it is preventable. And how do we deal with it is mainly one is through training and through is to disruption, that is introducing technology along with medical field. So thank you, Zakia, for that.
Thank you, ma'am.
So Zakia, there's just a few things that I want to ask for the sake of our audience. With respect to time for each OSCE station, what is your opinion? How much should be, first of all, how many stations of OSCE you think we should have for having good validity? And also, what is the amount of time that we should be keeping for each station?
Okay. Well, first we need to consider our examinee cohort and what level of stage or what stage of training they're in, and then design the OSCE to that respect. Now, in terms of number of stations that you should have, it can vary anywhere between 10 to 25. The FRCA exam had about 15. In terms of timing of each station, it depends on what exactly are the things you're looking for at each station. Now, it can be of varied time. It can be varied time. And what would happen is the examiner would be notified of the time that they can allot the examinee. And then the examinee can be told at the end of that stipulated time that their time's finished and they can just have a seat in the same station. And the examiner can continue to reset their little station for the next examinee.
Right.
Now, alternatively, the time difference between all of the different stations can be utilized to organize rest stations. So I'm sure Payal will agree with me on this, that going through 3.5 hours of 15 different stations is quite a test of your endurance. You need to have the ability to reset and carry on for the next one. So I'm sure all the candidates will appreciate a rest station or two.
Excellent. So Zakia, also you said that there is enough evidence that OSCEs are more reliable than the traditional methods. But nevertheless, we do need to have the traditional method of assessment, and OSCEs will only add value to what we are already doing. Do you agree with that?
I completely agree with that. And the pieces of evidence that I did provide in this talk, all of them in unison suggest the same thing, that there's a positive correlation between OSCEs and also our traditional methods, and that's why they should be added on. They don't suggest a complete replacement of what we have, but instead an addition.
Excellent. So Payal, thank you so much for that elaborate talk on how to, conduct an OSCE, and for introducing so many concepts to us with respect to the matrix and the borderline candidate. Most of us were actually introduced, at least I was doing the OSCE stations with using simulation, but this introduction of the borderline candidate was something new to me as well. So I think moving forward, we'll definitely do more OSCE stations and, take up the scoring, borderline scoring, and identify the borderline candidate as well. Payal, with respect to what you spoke about, the importance of the checklist. Do you validate your checklists at your center, and how important is it?
It is highly recommended to validate the checklist, because
Okay.
as a station designer, if I formulate a checklist and I jot down that these items are important and these are likely important because it demonstrates what a competent candidate is for the stage of training. Now, when it is revised by 2 other experts, they may find that they may not agree with all of the 10 items. They may feel
Right.
that there are maybe there are 2 or 3 other important items. So we need to reduce the ambiguity, and we need to ensure that all the 10 items on the list will be most likely answered or checked off by all of the competent candidates, or the candidates who are above the grade of borderline. So,
right. And also, I think it was really important that you showed us how you, based on our target audience, that's the student level, what is the expectation from each of them? Like undergraduate, it will be one set of one level of competence, then adding layers to that with interns coming in, and then adding some more of advanced layers to postgraduates. So your checklist was based on your target audience and what is the expectation out of them. And you also included both the global rating scale and also the weighted checklist together. And I think that was wonderful because you've incorporated both the kind of checklist in one checklist, right?
Yes, ma'am. I've used both the global system and the numerical scoring system. And I think that adds value and also increases the objectivity.
Right.
There's lesser room for bias.
Yes. So thank you so much, Payal and Zakia,